One of the things that hints that someone may be having a stroke is they're not conversing with us the way that they used to when it first came in, or the speech becomes slurred, or they're sluggish in response, and that usually tells us something's going wrong.
The Code Stroke Protocol is a series of steps to help people go through the process of early identification of a patient with stroke symptoms, and then what to do step by step to get a patient down to emerge into the CT scanner and get a diagnosis and get timely treatment.
Well, one of the things that we want to do with public education is time is brain. When there is a stroke, when there's a blockage of the blood vessel leading up to the brain, the part of the brain that is involved is lacking oxygen, and very quickly there is irreversible damage to that brain. And we know that in the literature that patients with acute stroke in hospital, they do not do as well as patients that are in the community. And this really doesn't make sense. They should be getting better care because they're already in the hospital. So we developed this protocol to try to improve stroke care for inpatients and really catch up to what we're doing in the community.
The protocol outlines the steps from identification to imaging and treatment, and the roles of the most responsible nurse who finds the symptoms in the patients, and to the physician and the neurologist, and the role of the unit coordinator is well explained in the protocol.
I really like the Code Stroke Protocol. Ever since it's been implemented in 2014, it makes it the whole thing much more smoothly.
In our emergency department, the CT scanner was made available 2 years ago, so it was very timely for us to develop this protocol where we could send our patients to the ED department. And from there, if the stroke is diagnosed, and if the patient is ischemic stroke and eligible for IV TPA, which is the clot-busting drug, the patient will be moved to ER trauma bay, where the drug will be administered. And from there, the patient will be moved to a critical care bed where a patient should be monitored at least for 24 hours until they are neurologically stable.
So as soon as the requisition prints, we have a procedure in place where we don't need to get the rec protocol. We don't wait for the GFR and creatinine, which is the renal function of a patient. With the stroke protocol, the stroke comes first.
I think it's an exciting opportunity for us to be a part of inpatient care that we aren't a part of. And I think it allows the hospital to utilize our resources to the best that they can be, right? In terms of we're probably the place that has is able to accommodate these patients most easily, because we're used to patients coming and going quite quickly and without much warning.
We have shared this protocol with other centers both across the region, and we've presented at national conferences, and people are coming to us to say, how did you do this? How were you so successful at getting this up and running?
So many people have helped to refine this protocol. I have to mention the support of the ER staff, CT technologists, our CRNs, and the nurses and unit coordinators, and our neurology team who has been very helpful, and our cardiologist, CTU physicians. I thank everyone for the support for the successful implementation of this Code Stroke Protocol.
Bina was the leader through this whole Code Stroke Protocol implementation. She really kept us on track, and every time we had a Code Stroke activation, Bina was notified. She went down to emerge, she reviewed what happened, where we could improve, gave the feedback, worked with the team to really improve the process. And I think because of her leadership, we were really successful.